red arrow is pointing to what lungs look like with emphysema, these sacs that are much larger that don't work as well as they should. So we know emphysema is a huge problem, and you'll see all of these statistics. It affects almost 5 million people in the US alone. It's the third most common cause of death. It causes over $50 billion in healthcare costs. These are the stats that you see. The thing that I think is the most important and the biggest burden of emphysema is that it significantly impairs quality of life. And for me and for my patients, that's the thing that matters the most. So I think that's where the valve really comes in, which we'll talk about, because its biggest impact is on quality of life, which I think is the most important thing that we look at. So how does emphysema, this destruction of this little ball of grapes, essentially, how does that affect your breathing? Well, as the integrity of that structure gets degraded, you lose the elasticity, which just means the ability of that sac to move in and out and exchange gas. And so as that happens, you start to breathe air in, and it gets trapped in those little sacs. It's not able to leave the way that it normally would. So you start to increase the volume of your lung and cause hyperinflation. So that causes impact on the muscles of respiration in the chest. It causes impact on the muscle of breathing called the diaphragm that helps move air in and out. As things get bigger, those muscles don't work as efficiently. So this is a good example. This is a normal chest x-ray. And you can see with this blue line going up and down, this is in the normal size of the lung. You can see with this shape here, this is the diaphragm. It has a nice rounded contour to it. So this is how things should look. Compared to an x-ray of a patient who has emphysema and hyperinflation. You can see with this red arrow, the size of the lung is much bigger than normal lungs. And here with this red circle, you can see that the diaphragm is much more flattened. So you can see how this would really affect how you breathe, because your lungs are too big for the area where you're supposed to be breathing. Ultimately, that hyperinflation causes shortness of breath. When you're short of breath, you decrease your activity. Then you reduce your overall exercise capacity. You can feel even more short of breath because then you're deconditioned and not exercising. And it's this vicious cycle that ends up happening with patients with emphysema. At the end of it all, there's a higher risk of death with emphysema, along with deconditioning and everything that leads up to it. So there are a lot of impacts to this, mainly quality of life, which again is what I think is one of the most important impacts. So there is higher mortality with emphysema, and we see that here with a study that was done in 2001. Patients who have more hyperinflation have more problems, and that's the line that I have marked here. Ultimately, the quality of life things are more shortness of breath, less ability to tolerate exercise, lower oxygen levels, lower ability to complete daily activities, lower muscle strength, and even has some heart impacts. So there are a lot of impacts that you can have from emphysema. So that's all the news that probably you guys know, and the things that aren't fun to talk about. And what I think is more exciting to talk about are what can we do about emphysema now to help treat it. So this is how things used to look. Medical management, which is very important. Pulmonary rehab, which is essential. Once you got to that point, the only options then were maybe surgical lung volume reduction, which I'll talk about very briefly, or lung transplant, which are huge surgeries and are not appealing options for a lot of patients. Thankfully, what we have now, and what's been studied for years and actually used in Europe for many years, but has finally been FDA approved here in the US last year, are the endobronchial valves. And so that's what I'm going to talk about a little more specifically. I have to touch on medical management because this is an absolute core of treatment for emphysema. The valves that we're talking about today do not supplant the need for medical management. Everybody should have maximal medical management before we're talking about doing anything invasive. Smoking cessation, you guys know this part is huge, and there have been study after study after study showing that mortality is lower if you stop smoking, showing that lung function decline reduces, showing that cough and sputum get so much better if you stop smoking. So this is a core part, as you know, of treatment for emphysema. Medications, there's so many out there. And they come in all different formulations. They have medications that, dispense 1 or 2 or 3 medicines. So there are a lot of different types. And these are things that myself and my partners, Dr. Wong and Dr. Chilyat, will go through with you in your pulmonary appointments to make sure that everything is maximized from a medication side. These medications help open up the airways and can help you breathe better. Pulmonary rehab is essential, and it is a guideline for most patients with COPD, patients with GOLD B, C, and D. So patients with A who are not as severe, I think everyone can benefit from pulmonary rehab personally, but the guidelines say everyone with B, C, and D should be involved in a pulmonary rehab program. Frailty is a thing that can affect patients with COPD as the muscles get weaker and you're not breathing as efficiently. And early on, some people thought that maybe frailty was not going to allow you to participate in pulmonary rehab. And it's the absolute opposite. And so many studies have shown this. One of the big studies was published in 2016, and it looked at over 800 patients with emphysema. And about a quarter of those patients met criteria for frailty or weakness. After they participated in pulmonary rehab, over 60% no longer met those criteria. So frailty, and that's the word that's used in the studies, is not a contraindication to pulmonary rehab. I think it's an indication for pulmonary rehab because it can be tailored to any level and any patients. I'm a huge proponent of pulmonary rehab. And ultimately we know exercises, yes, education, yes, but support. Well, pulmonary rehab provides for patients. I think one of the biggest things is a supportive environment. So again, I go on and on about pulmonary rehab anytime I speak because I think it's just an amazing resource. So moving on from the medical treatment, for a long time, other than lung transplantation, there was just surgical lung volume reduction. And this is a very simple diagram, but it shows exactly what surgical lung volume reduction is. A lot of times the disease with emphysema is in the upper parts of the lungs. So they look at that, and if you're a candidate for surgical lung volume reduction, they lop off the top lobes of the lungs. As you can imagine, this is a big surgery. There are issues with this surgery, and it hasn't become very popularized for a lot of reasons. And I'll show you just very quickly why that is. The NET trial in the early 2000s is what really got us looking at treatments for emphysema. Surgical treatments initially, and then some of the things that we've piggybacked these valve studies off of. And it showed that certain patients with emphysema would do better if we could block off that really diseased portion of their lung. And by block off, initially we were talking about surgery. You take it out and it's gone. Can't put it back. More recently, there was a study done in 2014. So this is 13 years after that trial was published. And it was done by surgeons saying, how many lung volume reduction surgeries have we done in the country? Is it effective? Are people using it? And then looking at this time period, only 538 surgeries in the US had been done surgically. They showed that the mortality was actually higher than what they had anticipated in the trials. And there was a lot of concern over having a big surgery, being hospitalized, pain at the surgery site, a lot of the issues that can come with big surgical procedures. Additionally, it's limited to very specialized centers. So I think that's another reason why it hasn't really taken off. So what we're going to talk about now, what I think is so exciting, is that there is now a way to collapse the portion of the diseased lung that's involved the most with emphysema without actually taking it off and throwing it away. And that's what we're going to talk about with endobronchial valves. So what are they? How do they work? What are some of the complications of putting these valves in? What should you guys expect in the pre-workup for valves, for the actual valve placement, and then afterwards? These are things we're going to talk about today. So these are the two valves that are on the market in the US. One is Zephyr and one is Spiration, and I put pictures of them up there. I actually have a little Zephyr valve with me, so I can show you guys at the end of it if you want to see. It's very cute, actually. And it's much smaller than you would expect the way that it looks up here on the monitor. So these are valves that are made of a material called nitinol and silicone, and they work as one-way valves. They've both been FDA approved for lung volume reduction, but what I'm going to talk about mainly today is the Zephyr valve, because that's really what I like to use for lung volume reduction. So this one-way valve allows the lung, wherever we put the valve, the lung behind it to collapse, which is a good thing. It's going to shunt air from that area to areas of the lung that work more effectively. We're going to talk about exactly how it looks. So it collapses that area of lung, but it also allows secretions to exit. So now you're not going to deal with issues like post-obstructive pneumonias or secretion buildup, but you're going to get the same effect that you would of not having the air going to the diseased portion of the lung. And this is a picture here of just the framing of it and how it looks. I actually have some videos of valves I've placed, so I'll show you guys. I think you get a better sense when you actually see the video of the valve. So once we collapse that portion of lung that isn't working as well, we decrease that problem with hyperinflation. So the lungs were very expanded. Once we collapse that part that doesn't work well, the lungs return to a more normal size, which is a good thing for many reasons. It causes the diaphragm, now that muscle here that separates the belly from the chest, to work more efficiently. It helps your respiratory muscles in your chest work more efficiently. Air, oxygen is now going to areas of the lung that are less diseased, and you're going to trap less air because it's going to areas of the lung that have more recoil, that have more elasticity, that allow you to get the air out better. What is the evidence that this works? There have been a lot of studies. So even though this was just FDA approved last year, it's been studied for years and years. I won't go through every single trial, but I will say that it started in the early 2000s and has really taken off. And at first we were looking at patients who have disease just in the upper part of the lung. Then we were looking at patients who have disease in all parts of the lung. And we learned things along the way as to which type of patients do better with valves. And there's one key thing that I'm going to talk about that I feel like maybe a little technical, but it's really important to understand. And it's a concept called collateral ventilation. And I have slides on it. We're going to go through it because that's really the key to say who's going to benefit from valves and who isn't. These are things that you can expect if you're a candidate for endobronchial valve therapy. Things like improved quality of life, improved exercise capacity, reduction in feeling short of breath or breathless, improvement in your actual lung function, and improvement in the gas exchange. You're going to trap air less. You're going to exchange oxygen better. I've had several patients come off of oxygen after they've gotten valves placed. But I think the biggest impact is in quality of life. So we have to talk about complications always, and if you come see me or anyone, we can talk to you further about these complications. They're pretty rare, all things considered, except for one thing. Whenever we put these valves in, it's a double-edged sword. We want the lung to collapse. That's a good thing. But sometimes when the lung collapses, we can cause a tiny tear in the tissue of the lung. That's called a pneumothorax. It means that air has gotten in place between the chest wall and the lung, and the air has built up there. That's the number one thing that we look out for. So if we end up placing valves, we always keep you in the hospital for 3 days afterwards, because that's the highest risk of lung collapse. If that happens, we can deal with it. It's not a thing that we need to go into extensively here, but it's something I always talk to my patients about as a risk, and that there are ways to deal with this and that everybody gets out of the hospital just fine. Less commonly, the valves can move. You can cause a little bleeding around the valves, but these happen very rarely. So again, if we were to talk about actually putting valves in, I would go through all of these things with you very extensively. But in general, this is just a summary of side effects of valves, because that's a question that patients always ask me. If you have a pneumothorax, we can treat it. We put in a tiny tube here, we suck the air out, and the tube comes out. It doesn't sound great, I know, but again, this is one of the most common questions that patients have for me, and if you want to ask me about it later or come see me in the office, we can go through it more extensively. So what does the pre-procedure evaluation look like? If you say, hey, I think I may be interested in these valves, what are things that we're going to get? What can you expect in the office? We're going to get pulmonary function tests. There are certain criteria that you need to meet to say that, yes, I think valves would be a good benefit for you. We don't want to put valves in patients who aren't going to do well with them. So We always get pulmonary function tests beforehand. Usually I get an echo, which is an ultrasound of the heart to make sure that the heart is strong enough to undergo a valve procedure. And then we always get a chest CT. And so this is coming back to that concept that I mentioned called collateral ventilation. And that's really what determines whether or not you're going to be a candidate for endobronchial valve placement. And again, we can go over this and over this and over this because it's a lot of information, but I would say this is one of the key concepts to take out of this. So collateral ventilation means that the lobes of the lung, the 3 on the right and the 2 on the left, communicate through channels that are not the main airways. So they sit right next to each other and have little passages. This is essentially what it looks like. You can see how normally it gets fed by the airway tree, but sometimes these lobes communicate on their own, not via the airway. And if that happens, that means that there is collateral ventilation. We call it CV positive. Some patients have no collateral ventilation. That means that there's no communication between the lobes of the lung and that the air is only coming from the airways. Those are the patients who do well with valves, because that means that if we block off that airway with a valve, it's actually going to collapse. If you have places that are being fed airway, not airways, but communications between the lobes, if we put the valve in, that area is never going to collapse because you're going to keep getting air circulated through these other channels. So this is the biggest thing. This is what we learned with all of those studies. The patients who have no collateral ventilation are the ones who do well with valves. This is a sample of a report that if you see me in the office and I get a chest CT, I upload this to a special type of software that tells us if there's a high likelihood that the communication between the lobes does not exist. And it's software that I think is really important to use when we're evaluating if you're going to do well with valves or not. And it takes a little bit to come back once I see you in the office, but when we get this report back, it gives me a good idea of if you're going to be a candidate for valves or not. So then say, yes, this report comes back and it looks like your valves are going to be a good option. So I have a picture here of UCLA Santa Monica, which is where I've started doing the valves. The hope is actually that we're going to expand to Providence Little Company of Mary and maybe Torrance Memorial. So I think getting more hospitals on board is better, but for the time being right now, I'm doing the procedure at UCLA Santa Monica. You would have nothing to eat or drink 8 hours before the procedure. You would come to the hospital 2 hours before, check in, they'll put a gown on, they'll put an IV in, I'll come see you, all of my staff will come see you. You'll be wheeled to our operating room, which I took a picture of yesterday. This is our cleaning crew, so. We'll move you over to the table, put a bunch of monitors on you, and then we'll get you off to sleep. This procedure is done under general anesthesia. So once you're asleep, the bronchoscopy starts. And the first part of the bronchoscopy is using a fancy type of equipment called a Chartis system. This is just to make absolutely sure that you don't have any communication between the lobes of the lung. So we want to make sure that you are collateral ventilation negative. So this is, I think, one of the really important parts of this procedure, because if you do have collateral ventilation, we should not put valves in you. At least that's what the data says right now. So we do this part of the procedure first. Again, you're asleep for all of this. This is a picture I took yesterday, actually, of the little catheter and the balloon in the airways. So this just tells us whether or not that collateral ventilation exists. And once we say, okay, there's no collateral ventilation, yes, we're going to put valves in, this is how they look. So this is a nice little diagram of how this guy sits in the airways, and it allows the area to collapse behind it, but allows things like secretions and whatnot to exit. And I have a video here of valves that I put in, not yesterday, but a couple of weeks ago, or that we as a team put in. And you can see here, this is the airway. All that pink is the airway, and the white is the catheter. You're going to see the valve start to poke its head out there. So we're deploying, deploying, deploying. You can see we're pulling the catheter back, and ultimately you're going to see the valve pop out and see how it looks. So it's all just done through the mouth and the airway. I have a closer up of that. So this is a zoomed in version of that little valve, and you can kind of see its duckbill moving up and down. So that's just it moving with breathing. But that's what it looks like inside the airway. And again, I have one valve with me. It's about this big, so I'll pass it around so you guys can see it. After the procedure, you're obviously going to wake up and see my face and my team's face in recovery, and we're going to tell you, yes, we put the valves in, which is always good news. Patients always tell me, if I end up staying in the hospital, I'm going to be happy, because that means that I had the valves put in. If they're put in, you stay with us for a minimum of 3 days and 2 nights. That's to make sure that that lung collapse hasn't happened. We'll be getting x-rays every day. We're going to be asking you to get up and walk around and seeing how you're feeling. And as long as that lung collapse doesn't happen, you go home after 2 nights. Afterwards, I see you in clinic in a week. Then we talk about clinic visits at 30 and 45 days, then 3 months, 6 months, 9 months, 12 months, and then every year after that. And at various time points, we'll get repeat pulmonary function tests, we'll get repeat walk tests, you may have a repeat chest CT, but the biggest thing to me is that you're going to tell me how you're feeling, and that's how we're going to know how well the valves worked, because I think that's the most important outcome from all of this. But that in general, because again, one of the most common questions that I have for patients is, okay, well, once they're put in, what do I do? Do I see you again? You know, who do I talk to? You'll see me often afterwards. So ultimately, at the end of the day, I think maximizing medical management is the thing that's most important, because we want to do the least invasive thing first. But once we've gotten to that point and people are still having symptoms, I think considering things like an endobronchial valve is really reasonable. Studies have shown over and over again they're safe, they're effective, they're reversible. So if for some reason there was an issue, we can take them out, unlike things like surgical lung volume reduction where that part of diseased lung is gone. So if there's an issue, we're not putting it back. I think this is an amazing thing that's developed in the world of emphysema, which is why I'm here to talk today. So, with that, it was perfect timing, because that's the end of my talk, so.
Wow, interesting.
At this point, I would take questions. Oh, hi, question.
When you have done this procedure, does it last for a long time, or don't you know yet?
Well, so we have studies that have looked at 1 year and 2 year follow-up, and patients do really well. We've had patients that we put valves in from studies at 5 years who have actually looked great and have still had, have still had symptomatic benefit. So definitely, yes.
You haven't been that long enough to ever have replaced them with these valves, with new valves, or anything like that?
So occasionally, when valves go in, they can move a little bit, and sometimes people don't get as much benefit as they might. So if that were the case, I'd be seeing you in clinic, you'd tell me, I don't feel that much better, I feel a little better, but now I don't feel as good. We would get a repeat CT scan to make sure that the position of the valve still looked good. I might run another report, the fancy Stratix report, to see if it looks like that lung has collapsed the way it should or not. And occasionally we have to go in and revise the valves. Thank you.
You've never had to replace one.
Well, occasionally we've taken them out and put a new one in a better position. It doesn't happen very often, but it has happened. So again, these are all things, any procedure, there's always different side effects and things that can happen. So these are things I usually talk about in clinic once we get to the point where we say, yes, you're a valve candidate, we've done all the pre-procedural workup, we've gotten the report back. Then I kind of go through all of these scenarios just so people know what to expect. But it doesn't happen very often. Oh, I do, yeah. Go ahead, please.
Yeah, I finally found an orthopedic surgeon that will replace my knee. Where my primary put a stop to it because of my breathing.
Okay.
And the anesthetic.
Yeah.
You got to do different with people with breathing problems and anesthetics.
Well, so that is a kind of a separate thing from talking about the endobronchial valve. Certainly, or do you mean patients with severe emphysema and general anesthesia in general?
COPD.
So our anesthesiologists are specially trained to deal with patients who have respiratory disease, and we as interventional pulmonologists, that's what we specialize in also. So basically every procedure I end up doing is on a patient who has bad lung disease. In general, for things like orthopedic surgeries or what they consider elective surgeries, a lot of times the team is not comfortable dealing with patients who have lung disease. That's all I see. I would not put valves in someone who didn't have lung disease. So, you know, I can't say exactly what it is that we do differently per se, except that we are highly specialized and trained in dealing with patients who have bad lung disease. So we have anesthesiologists who are accustomed to dealing with that too. A lot of it has to do with comfort with the airway. A lot of times it has to do with the different volumes that you use with general anesthesia. Because when you're under general anesthesia, we give you breaths, or the anesthesiologists give you breaths. So a lot of times we tweak those settings to make them more optimal for patients with emphysema. There's different types of anesthetics that we use, sometimes for patients who have COPD or emphysema. So, you know, those are different types of things that we use in this setting. But like I said, every patient I see that we put under general anesthesia has bad lung disease.
Yeah, my primary said he's afraid I'd wake up and be on the breathing machine or nothing like that.
It's a very common fear in patients who have bad lung disease. And in general anesthesia is a risk, right? But, you know, I thankfully have not had any adverse issues with general anesthesia in patients who have bad lung disease for this procedure. It's a pretty short procedure at the end of the day, so.
Dr. Oberg, how about patients that have a high FEV1 but low DLCO?
So you have to have an FEV1 between 15 and 45%. So that's the criteria, 15 to 45%. So you need to have enough, you know, issue getting the air out, and you need to have enough hyperinflation, meaning that your lungs are too big, and that air trapping, meaning you're not able to get the air out. Those are all things that we look at. The DLCO not so much, but the FEV1, the TLC, and the residual volume are things that we look at, and there are specific parameters that we will that we assess when we get the pulmonary function test.
So if you had a high FEV1, you wouldn't qualify?
Correct. Above 45%, no. Yeah.
What does that mean? The question I have is not just for myself, but we have several people that have pulmonary fibrosis.
Mm-hmm.
So this is strictly for people with COPD,
Yeah,
not
with
pulmonary fibrosis.
Correct. Yeah.
Very good. Thank you.
Yeah, I wish. IPF is such a it's come a long way in the last couple of years.
Really?
You know, with medications, anti-fibrotic medication.
For those
but,
that can take it.
Exactly, but I wish there was a valve or something we could do for that, but unfortunately just for patients with emphysema. Yeah.
Thank you.
Two quick questions. How long does the surgery take, A, and B, what does this do at airport security? You have none in your body?
It doesn't go off in the machine, so don't worry about the airports. Yes, that's a great question. It's a question I get a lot, actually, so you're not going to be triggered by TSA, you know, and taken in a little small room. The procedure-wise, it depends on if we put the valves in or not. So I always do that Chartis procedure, which is the balloon, to just see if you have collateral ventilation or not. If you do have collateral ventilation, after 20 minutes, we're going to wake you back up. That balloon test, I would say, takes about 20 minutes or so. And if it's there and we've tested it a couple of times and there's no area to put the valves in, 20, 30 minutes, and we're going to wake you back up and tell you, unfortunately, we couldn't put valves in. If we do put valves in, it depends on which areas we're going to put them in, but I would say that takes another 30 minutes or so. So in general, if we're doing the testing and we put valves in, I would say maybe an hour and 15 minutes overall, door to door, and then we're going to wake you up and take the breathing tube out and take you to recovery and all of that. But the procedure-wise, a little over an hour if we put the valves in. Yeah. Please.
Do you have to go on a maintenance medication the rest of your life like we do with a transplant or something?
No. So immunosuppression, those are the types of medications you're talking about with transplant. There's nothing like that for the valves. I do have everyone continue their inhalers that they were taking beforehand. So things like Trilogy or Anora or Spiriva, Symbicort, you know, the cocktail that you were on beforehand, I continue afterwards, absolutely. But there's no new medication that you would take for the valve specifically.
Like an anti-rejection thing.
Exactly, no, none of that.
If a patient has some emphysema, but the major problem is pulmonary artery hypertension, would they be a candidate for this as well?
So that's one of the reasons that I get that echo, the ultrasound of the heart. If the pulmonary hypertension is bad enough, we typically, I always look at it on a case-by-case basis, always, and it depends on what's causing the pulmonary hypertension, if it's just the COPD or emphysema, or if there's another cause for it, how severe it is, how much it's affected the right side of the heart, because that's the big fear with pulmonary artery hypertension, is that you can get right heart failure. So it's a relative contraindication if the pulmonary artery pressure is high enough, but it's something that we look at and we figure out why it's there, and can we give you medications to kind of decrease the pressure, and if it hasn't affected the right side of the heart, and I think you can tolerate general anesthesia, then it's something we talk about, yeah.
How many valves do you typically put in, or is there a maximum, or?
No, that's a great question. So yesterday I put in 3. I put in one lobe of the lung, I put in 3 valves. Sometimes I would say we go up to 6, so anywhere between 3 and 6. You know, we don't typically put, because each lobe of the lung has little segments that branch off and subsegments, and that's where they get smaller and that airway tree really starts going. And we want to make sure we put in enough that we block off all of the areas so there's no leaking from those airways. The valves are sized, and we have little sizers that we use, so we size them to your airways, so it depends. I can't ever say exactly how many we're going to put in, but somewhere between 3 and 6.
Unlike lung transplants, is there an age limit that you have a cutoff for? Curious.
Typically, no. I mean, again, there are things that are relative contraindications, and certainly patients who are older don't do as well with anesthesia. But if somebody came to me who was 85 and was in enough shape that I thought they'd be able to tolerate general anesthesia and met all the criteria and the ultrasound of the heart looked good, then we would go ahead. Yeah. Sure. Yeah, go ahead.
If I were to get this valve procedure done, would I qualify for additional surgeries then?
Meaning surgical lung volume reduction for the lungs, or what other types of
Like
surgeries?
surgery.
Oh, yeah.
General anesthetic.
I see. Would they say that now you can have your orthopedic
Yeah,
surgery?
yeah.
Possibly. You know, if you qualified for the valves, if you didn't have collateral ventilation and we actually put them in, if you got the collapse that we were expecting, a lot of times lung function does improve. So if all, it's a lot of ifs, right? But if all of those things happen, which they commonly do when we put in the valves, I think you would probably be a better candidate for general anesthesia. It's an interesting question. It's not something that we've studied as of yet, you know, all of these downstream effects of putting valves in. But, you know, if your lung function improved and your symptoms improved, you would probably be able to tolerate general anesthesia better.
Or call your anesthesiologist.
Yeah, all of the, you know, it's like these are all conversations. So certainly it's tough. Patients with lung disease and having surgery is really difficult. And again, it's not something that we've studied as of yet, but I think it's a really interesting question, because if your lung function improves, you in theory should do better with general anesthesia and might actually be able to have other procedures done.
Thank you.
You're welcome. Other questions? Oh, I see in the back. Hi.
Hi. If you're with one of the 2 doctors that you're with, do they automatically refer you?
They have been. Yep. Yep. Dr. Chulia and Dr. Wong. So I have cards. It's the same office. It's the same number. So if you're interested in coming to just meet and see how, you know, talk further about the valves or actually have an evaluation, we can do that. But yes, Drs. Chulia and Wong have been referring me a lot of their patients. So, yeah.
Is there an age limit?
Ultimately, I would say no. You know, there are you don't tolerate anesthesia as well sometimes the older that you get, and studies are always done in a certain patient population, but age to me is something that's relative. So I think if you meet all the criteria for valves and you're otherwise in pretty good health, that valves would be an option. Yeah, so there's no hard age limit, no.
I want to say something. We have had a lot of speakers. You are incredible.
have absolutely made my week.
Dr. Oberg, I think, honest to God, you are just an outstanding speaker. And I was going to say to Jackie, I wish all our speakers could be as good as you. She is absolutely wonderful. If you have additional individual questions, you could please grab her after the luncheon program. But again, thanks Dr. Oberg, thanks Mary. And let's give them one more round of applause, a lot of energy. Thanks everybody. When are we going to see each other again? At the Halloween party and the happy hour, okay? See you then. Drive safe. Huh? And don't forget to stop by and get one of your prepaid addressed envelopes in case you would like to make a final little donation to our fundraiser. Okay? Thanks everybody. Take care.
Hey, she's nice out. All right, ladies. See you again next month.